I am Dr. Sita Kandan-Sivaraja, a GP partner based in Dartford, and I will be your moderator for this evening. Thank you all for joining us today. JMFOA has been hosting this educational webinar for nearly 5 years, covering a wide range of both clinical and non-clinical topics. One of the core aims of JMFOA is to support our members in developing and enhancing their career prospects. This webinar series is one of the key ways in which our charity works to achieve this mission. Today's topic is ophthalmological emergencies for primary and secondary care clinicians. It's a highly relevant topic across multiple settings, including general practice, urgent care, A&E departments, and other hospital environments. We'll be focusing on how to recognize, manage, and appropriately refer eye emergencies in a timely manner, ensuring they are addressed before complications arise. Why this topic matters. Around 1.5 to 2% of GP consultations are related to eye complaints. Of these, a small proportion, approximately 5 to 10%, are true ocular emergencies. Eye emergencies account for roughly 1.46 to 6% of all A&E attendance in the UK. While many of these cases are minor, a few can result in permanent vision loss if they are missed or mismanaged. Today's session, we will focus on how to recognize this high-risk presentation early so that timely and appropriate intervention can prevent serious outcome. Before we begin, just a few quick reminders. Please keep your microphone muted unless you are invited to speak. Feel free to post your questions in the chat box at any time, but we will have a dedicated Q&A session at the end. This session is being recorded and will be made available to you afterwards on demand. Thank you for your cooperation. Now, it's my pleasure to introduce our speaker, Mr. Deva Loganathan, a consultant ophthalmologist and glaucoma specialist at Mid and South Essex NHS Foundation Trust. We both graduated from Faculty of Medicine, University of Colombo in Sri Lanka, and he was my immediate junior during our clinical training. Deva completed postgraduate training in Sri Lanka, and he is a board certified specialist in Sri Lanka and had further training in UK with CCT on ophthalmology. He is working as a consultant ophthalmologist with specialist in glaucoma. His brother studied in Jaffna Medical Faculty. Mr. Loganathan brings extensive experience in both hospital-based and primary care ophthalmology, making him specially well-placed to speak on this topic today. Outside his clinical work, Loganathan is also a talented singer. So we are privileged to have someone with both clinical and creative flair with us today. Without further ado, I will now hand over to Loganathan to begin his presentation. Thank you.
Yeah, thank you, Dr. Sita. Thank you very much for the kind introduction. So today I was asked to discuss some ophthalmological emergencies relevant to both primary care and secondary care clinicians. Can you hear me? Oh. Hello?
Yes, we can.
Okay.
Yeah.
So the topics I'm trying to cover is assessment of patient presented with the complaint of red eye and differentiating the etiology and determine whether they can be managed at primary care or need further referral. And if time permits, I will touch on tips on assessing the double vision, which is again a confusing topic for most of the primary care physicians. So the red eye is a common presenting complaint in primary care practice. Proportion of patients need urgent ophthalmological referral. And there is no evidence-based guidelines to manage these patients. And we all need a systematic approach to narrow down the diagnosis so that we can appropriately refer to ophthalmological services. So only available tool you have is patient history, measurement of visual acuity, and findings on pen light examination. And or you have 10 minutes on your consulting time. So it's a very challenge for any primary care physician to deal with ophthalmological care. So there are a variety of pictures. Any one of them can come through your consulting room, and it can be challenging to differentiate which one is. All of them are red eyes, and is a variety of reason for that. And unless you have some pre-planned systematic approach, you will miss some of the important clinical scenarios here. So either you are making a phone consultation, or if you are dealing with the patient face to face, there are a few questions you need to answer. So first question is the vision affected? Can you still read the ordinary print with the affected eye? It's a very, very important question to answer. So you can ask directly to the patients, how bad is your vision affected? Okay. And is there a pain that is acute in onset, and is it progressive and not relieved by analgesia or interfering with the sleep? That means I'm dealing with a really severe pain. It's not mild, foreign body sensation and mild aches. Here we are dealing with a really painful eye. Then you had to ask for, is there a foreign body sensation? So most of the time when you're seeing a patient with foreign body sensation, they will be seeing like scratchy, gritty sensation, sand in the field. That's not what we are interested in. We are interested in objective foreign body sensation, where the patient is unable to open his eyes or unable to hold the eye open. So these are the objective foreign body sensation. That is a cardinal feature of corneal process. So you have to elicit, is there a foreign body sensation? Does it feel through that there's something in your eye interfering with the ability to keep your eyes open? This is very important to establish to get that diagnosis narrowed. And is there a photophobia? Are you sensitive to light? Again, the patient with a cataract might complain that he can't see the fluorescent light and bright light. That is not something we are expecting. These are subjective photophobia. We are expecting a patient with objective photophobia, where patient can't see the light, looking down, or wearing a sunglasses, or wearing a cap, covering these eyes with the hands. That is an objective photophobia. That's what we are looking for. Is there a recent trauma? Is the eye had an eye surgery? Is he a contact lens wearer? And lastly, the sixth question you have to answer, is there a new onset of binocular diplopia? If you find the answers for any one of these questions, yes, then that means you are dealing with a serious eye problem. Most likely those patients will be needing ophthalmological attention. So these are very important questions. You have to get it correct when you're dealing with this patient. So ophthalmology examination, I know most of the practices, they don't do visual acuity. So visual acuity assessment is essential. You have to separate, you have to check each eye separately, and it has to be done before shining the light into the eye or putting any drops into the eye. You need only simple tools like Snellen chart and an occluder. It doesn't need an expert training. Anybody should do that. In our practice, we do HCAs do the test, visual acuity assessment. This will, if you can arrange somebody to do, anybody registered with a eye problem, any ophthalmological problem at the reception should first go to a visual acuity assessment. Even the receptionist can be trained to do that. It takes probably a half an hour training to do anybody to have visual acuity assessment. This is very, very important. So this will help you to narrow down your diagnosis, and it helps to assess the seriousness of the condition. And it's important when you are trying to refer to the hospitalized service, we will be expecting visual acuity from the person who are referring this patient. Then you have to examine, you have is only a pen torch light. I would probably recommend a pen torch like this, which has the pupil gauge and cobalt blue filter. Is very, very useful kit to have it in your practice. So when you're examining the pen torch examination, you are assessing the pupil, you are assessing the anterior segment, and lastly, you are going to stain the eye with the fluorescein to assess any corneal aberrations or any surface damage which are not seen with the pen torch examination. That has to be done as a last. So when you're examining the pupil, are the pupil round, equal, and respond to light like a direct light reflex or and consensual light reflex? And also you have to check for accommodation. So these are the steps you attain. So you look at the pupil, whether it's reacting or not, whether it's reacting to the direct light, or does it showing any consensual reflex to the other eye, and is it showing any constriction to the accommodation? So these are the few things you are looking at. Is the pupil is very small. In the case of iritis or the anterior uveitis, or if there's a corneal damage due to corneal aberration or keratitis, the pupil will be small, very pinpointed, 1 to 2 millimeters. And in the case of iritis, the pupil can be a bit irregular. So these are subtle things. If you note, then it will help you to narrow down your diagnosis. And is there a purulent discharge? Purulent discharge indicates bacterial infection, either it's a conjunctivitis or keratitis or corneal ulcer. So these are a few things which can be found with just pen light examination. So then you have to establish the pattern of redness, whether the redness is in the conjunctiva covering the eye, that's we call it a bulbar conjunctiva, and the surface covering the inner part of the eye, we call it a palpebral conjunctiva, and the fornix is where both bulbar and tarsal conjunctiva meet. So in the case of conjunctivitis, there will be a diffuse redness in all conjunctiva, mostly in the fornicial conjunctiva. So this is a characteristic of any form of conjunctivitis. It could be viral, which is the commonest, bacterial, or allergic conjunctivitis. You have to look at the distribution of the redness. In the case of keratitis or uveitis or anterior uveitis or iritis, you will have a redness or engorgement of the vessels around the cornea. We call it the limbus. This is called the ciliary flush or circumcorneal distribution. Circumcorneal injection is indicative of corneal pathology, that is keratitis or corneal ulcer or iritis. So these are the two different things you have to differentiate, whether the redness is in the fornix or mostly towards the fornix, or is it around the cornea or circumcornea. And you might see another corneal, another distribution of injection of vessel is in the sector. It's limited to the sector area of the sclera. This is mostly seen in episcleritis, which is a benign condition. All these three situations, the blood is within the vessels, but the blood vessels are engorged. But on the other hand, the fourth picture, you will see the blood is outside. This is subconjunctival hemorrhage. Spontaneous subconjunctival hemorrhage you will be seeing every day, which is benign, innocent. You don't have to do anything, just need a new reassurance. And the other thing you have to look at with the pen light examination, is there a white spot or opacity or foreign body? This can be seen with the pen light. If the patient is struggling to open the eye because of the pain, we normally use proximethicillin, which is an anesthetics. So that helps to comfort the patient so that patient will be able to open the eye. I don't know whether you have those in your practice. You can use some local anesthetic drops to numb the surface so the patient will cooperate with your examination. So pen light examination is good enough to spot the white spot, which is a keratitis or corneal ulcer, a foreign body in the cornea. It's only after this you have to think of other things, whether is there any hypopia? There's a pus in the anterior chamber. In the pictures in the second, which is a case of an anterior uveitis, you will see some fluid level, white pus, which is indicative of either keratitis or uveitis. In severe case, it could be an endophthalmitis. So hypopia is an important sign. And hyphema is a blood in the anterior chamber. This is red. So it's mostly seen as a complication of blunt trauma. So once you finish these steps, then if you don't find anything, if you still suspect corneal aberration or any other corneal damage, surface damage, then you can put the fluorescein and you examine the cornea with a cobalt blue filter light. So fundus examination, which is always a challenging for primary care physician or even the secondary care physician. In the case of red eye, I can tell you has not typically helpful in the differential diagnosis of red eye. So in the case of like conjunctival problem or lid problem, you won't see any association in the fundus. In the case of keratitis or uveitis, the pupil will be very small. You will not be able to check the fundus. In the case of acute angle glaucoma, of course, the pupil will be mid-dilated, but the cornea will be clouded. I don't think, again, you will be able to see anything on the fundus. And this is not needed most of the time in the red eye, except in the case of herpes zoster ophthalmicus, where the blister lesions affecting the ophthalmic division. Sometimes, if they have a blister in the tip of the nose, which is called the Hutchinson sign, so that's the distribution of the nasociliary nerve, those patients can have anterior uveitis and sometimes can have a retinal pathology. So those cases, if you can, you have to examine the fundus. So we'll try some cases here. So here we have here's a small known patient with a rosacea presented with a gradually enlarging painless lump. Vision is not affected. There's no discharge. Patient is happy with the vision, but it has developed over days and weeks. It's painless. And what's the diagnosis? Is a chalazion, which is not an infection, which is a lipogranuloma of the meibomian gland. And you don't have to treat any antibiotics for this condition. So mostly it is managed conservatively. 1/3 of the case will resolve spontaneously. We suggest hot compresses. So you have to do it frequently, at least 4 times a day. Then there's a chance it will resolve on its own. If that doesn't resolve, of course, we have to do a minor op to release the content. We call it an incision and curettage. So we do it with a clamp. So we rarely do the big chalazion, or if there's a lot of granuloma and conjunctival granuloma, then we have to do surgically. Most of the time, we can get away without doing any operation. But here, the situation is slightly different. Here, the patient wakes up with a painful, acutely painful nodule. It happens in a day, sometimes wake up in the morning with a painful lump, which is, we call it the hordeolum lump. So in the eyelid, I put a small diagram there to explain there are 2 sets of glands. One is a meibomian gland, which is on the tarsal plate, and there are glands associated with the eyelashes, like a gland of Moll or gland of Zeiss. Any one of these glands can get infected, usually Staphylococcus aureus. So when the meibomian gland get infected, as in the picture 1 on the left side, we call it an internal hordeolum. When the glands on the lashes get infected, we call it an external hordeolum, as in the bottom of the bottom picture. So both are infective. So they are localized infection. Most of the time, they are self-limiting. It opens up through the pointing pus, and pus get released, and it resolves on its own. Rarely, it can spread to the adjacent tissues and cause preseptal cellulitis. So this is in front of the septum, the infection very unlikely to spread to the orbit. So these are preseptal cellulitis. How do you differentiate the preseptal and the orbital cellulitis? Vision will be normal, eye will be white, eye movement will be full, there's no diplopia. This will differentiate whether it's an orbital cellulitis or preseptal cellulitis. In this case, the child is having a preseptal cellulitis secondary to hordeolum that need oral antibiotics. So this is another common problem you all see, blepharitis. So every, elderly person mostly will come with this very gritty, chronic recurrent symptoms like burning and grittiness, crusting, swelling of the ridge. It's very, very difficult to treat, and it never goes off. It have a recurrent and remission pattern. So it's a very frustrating condition to treat to anybody. The picture on the right is showing the meibomian gland disease. You can see the either it's over-secreting or is not secreting or is secreting a different consistent meibomian secretions. So this is what's called a posterior blepharitis. On the right-hand side, you will see the things are happening on the lashes. So on the top one, the right top, you will see there's a lot of crusting and hard scales, and the lashes are matted. These are staphylococcus-related anterior blepharitis. Whereas the bottom one, you will see this is a greasy, matted lashes. This is called seborrheic anterior blepharitis. So whatever the cause may, the blepharitis may be, the treatment plan is the same. So you really don't have to differentiate whether it's anterior or posterior, but the treatment is exactly the same. So, sorry. So, so you have to do a warm compression to make the secretions, to make the secretion and the crusting soft, and you need to include cleaning with the cotton bud or face cloth. And there are wipes available commercially. You can ask the patient to buy and keep cleaning. One thing you have to reassure, there's no cure for it. It will come and go, it's a recurrent pattern. So it's really frustrating for the patient, but you have to accept the facts. And also most of the blepharitis will have a evaporative dry eyes. So patient need a tear supplement in addition to all the lid hygiene. As in severe cases, sometimes we give doxycycline for, it's a low dose, 50 milligram once a day for 6 weeks. If there's a very bad blepharitis, we really don't know the action of it. It could be related to the decolonizing the bacteria, or it may be related to some metalloproteinase activities in the, it alters the secretion of the meibomian gland. So we really don't know, but it works. But it will be initiated at the hospital. Okay, so the next condition. So we are going to see a unilateral watery eye, redness, irritation, sandy or gritty feeling. The second eye get involved in 24 to 48 hours. No pain, no vision is affected. If you look at my 6 questions initially, I put it, so it doesn't fit in any of those questions. So this is something mild, so you can manage it, the primary care. So patient didn't have a visual change, didn't have a pain, and watery discharge, not purulent discharge. So all the questions, patients probably have answered no, no. This is what typical case of viral conjunctivitis. Start with one eye and quickly move to the other eye, and they have a minimum symptoms. This is highly contagious. Patient often have a history, somebody in the family had similar a few days ago or week ago. So, and no specific treatment needed. We usually give some preservative-free artificial tears to comfort the eye. And if you think there is a secondary bacterial infection on top of that, because usually patient rub the eye and mess up with the eye secretions and make it secondary get infected. In that case, you can give antibiotics, but most of the time try to avoid antibiotics. So here we have a different situation, similar symptoms, but the discharge has changed. So you have a purulent discharge, and on the right hand side, you will see a hyperacute purulent discharge. So various causes of bacterial conjunctivitis. So they have few isolates from the secretion. So commonest one is strep pneumoniae, Staph aureus, and Haemophilus influenza and Moraxella. And hyperacute purulent discharge is almost diagnostic of gonococcal infection. So that's so do we do any investigations? Not routinely performed, but in severe cases. And also, just forgot to tell you, so in case of a unilateral conjunctivitis, again, mucopurulent discharge with a painful preauricular lymph node, you have to suspect chlamydial infection. So in severe cases of conjunctiva, we do conjunctival swab, especially if we suspect gonococcal or meningococcal infection, we send for gram stain and culture. And if you suspect the chlamydial infection as with, conjunctivitis on one eye, it's not resolving, and if patient have a very tender preauricular lymph node, we have to suspect the chlamydial infection in a sexually active person. So we send for PCR. So how do we treat? So topical antibiotics, there's no evidence any antibiotics better than the other. So you can give chloramphenicol, ciprofloxacin, or ofloxacin, levofloxacin, any one of them is okay. So we tend to give cipro or ofloxacin, which is more nicer for the eye. The chloramphenicol sometimes can be very, very irritant, make the conjunctivitis worse. So is whatever you are comfortable with, you can use them. So in the case of gonococcal or meningococcal conjunctivitis, you have to use a quinolone or gentamicin. You have to topically, and also you need some systemic antibiotics like the generation cephalosporin, like ceftriaxone or quinolones, and you have to involve the microbiologist and the STD service. Haemophilus influenza is common in children. They need systemic antibiotics because they are high risk of developing complications like otitis and systemic problems. Okay, so the next is scenario is patients coming with a history of trivial injury. It's not nasty injury like doing a makeup and touch the the brush or the nail prick or contact lens uses. So those are the trivial injuries. So after that, patient presented with the severe eye pain, foreign body sensation, unable to open the eye, and marked reduction of vision. This is a typical presentation of any corneal problem. So it could be the contact lens related, or it could be an aberration, it could be a foreign body, or it could be a proper corneal ulcer. So this is the typical presentation of a corneal problem. So if you see in the last picture, you can see a large corneal opacity, which is a corneal ulcer. There's the serous sanguineous hypopion on the bottom. This is pretty nasty infection, very common with contact lens keratitis. If the patient presented after the contact lens, if you have slept with the contact lens overnight and presented to your consulting room with a red painful eye, and you suspect a contact lens related keratitis or corneal ulcer, you probably have to refer to us. And one thing I would say is, because most of the contact lens related keratitis can be serious and maybe Pseudomonas related, and don't start chloramphenicol. The Pseudomonas is 100% resistant to Pseudomonas, and it is a bacteriostatic. So you need a bactericidal drug. If you really want to start some antibiotics, start some quinolones like ofloxacin or levofloxacin. So don't start chloramphenicol in the suspected contact lens keratitis. So if you can't see anything with the pen light examination, then you go on to do fluorescein examination. In the first picture, you will see a linear scratch from a sharp instrument, either nail or something. It's staining and blowing out. So it is only at this stage you use the fluorescein dye test. The second distribution is a dendritic ulcer, typical pattern of dendritic ulcer. The third one is a corneal infiltration, possibly due to contact lens keratitis. And the fourth one is proper corneal ulcer. Again, the last one is a healing corneal epithelial defect. And so most of the corneal damage, as I said, it's very painful, but dendritic ulcer can be painless because the virus travel along the sensory nerve, and it can affect the sensation of the cornea. Even with a large dendritic ulcer, patient may not complain severe pain. It may feel like a foreign body sensation, but you will see a large pattern because of the cornea is almost like an anesthetic cornea. It doesn't, it has lost the corneal sensation. Okay, now the next is a patient present with a discomfort, moderate pain, or ache, redness. Vision is not affected. Again, you are dealing with a pretty straightforward situation, episcleritis. There's no treatment for it. So patient can take oral non-steroidal anti-inflammatory drug. That sometimes can help, but it's a self-limiting condition, doesn't need any treatment. And also it is a recurrent. Patient can have a previous history, so he can come time to time. Okay, so now we have a serious problem. So here the patient is hypermetropia. Hypermetropia is a long-sighted patient, which is a patient with a small eyeball. So wearing a thick glasses like plus glasses. If you borrow his glasses and see through his glasses, your computer screen will be magnified. So that's what the hypermetropia means, is they are wearing a thick plus lenses. So he is coming with a severe ocular or periocular pain and headache and photophobic, and he had a marked reduction of vision. So he will say it's the worst headache in his life, and don't send it to the neurology. Please open the eye and look at the anterior segment. Here you will see the cornea is a bit cloudy. The pupil is mid-dilated and not reacting to light. and you will see the distribution of the redness is around the cornea, which is called the circumcorneal distribution, which is a classic distribution in the case of anterior uveitis or acute glaucoma or corneal pathology, corneal ulcer. So this is acute angle closure attack. It's an emergency, so you have to refer to the patient very soon, very good. We like to see the patient within a few hours. We want to see the patient quickly and start the treatment. Okay, the next is again a very serious problem. Patient present to you, he had a cataract surgery, uncomplicated cataract surgery 4 days ago. Now he can't see anything with that eye. Cornea is hazy and full of pus. The conjunctiva is completely inflamed, and he has lost the vision. Serious thing. It's endophthalmitis. We need him very soon, very soon. We have to, every minute you delay is a problem. He's going to lose the sight completely, or he'll lose the eye completely. Okay, so this is a patient, it's a common, you will see the patient wakes up in the morning to shave, to shave the beard, and look, the eye is red. Otherwise, patient is asymptomatic, normal vision, no discharge, no photophobia, no foreign body sensation. This is spontaneous subconjunctival hemorrhage. So what we have to look for is very common after a Valsalva, like we cough or a sneeze, and it's just a bleeding outside. So sometimes patient may be taking some anticoagulant, or it may rarely patient may be having some bleeding disorders. So it doesn't need any specific treatment. Patient might say it has got worse for the following day. Usually the blood spread. So the second day may be slightly more than the first day. So don't get panic. Reassure the patient. Don't see it. But in the case of blunt trauma, subconjunctival hemorrhage is serious. So it can hide a globe rupture. This is very relevant to the A&E people. So any conjunctival hemorrhage with a swelling of the conjunctiva, you have to always suspect there could be an underlying globe rupture. So it's very, very important. In the case of penetrating injury, subconjunctival hemorrhage is the clue where the entry point is. So we have seen a couple of years, a patient is working in a building site, somebody was hammering a nail. So this patient was walking past by, and he felt as something gone into the eye, and he ignored it. And 2 days later, his vision went very badly. Then he came to us. We only found there's a slight subconjunctival hemorrhage. So actually the entry point is closed. There's a foreign body inside the eye. We were able to see, and we were able to take the foreign body out to save the eye. So it's very, very difficult. Subconjunctival hemorrhage is innocent, and it's spontaneous. It is significant in the case of trauma. So again, subconjunctival hemorrhage in a younger child, less than 2 years. If there's any without any verifiable history of trauma, you have to suspect non-accidental head injury. So you have to, on the fundus examination, you can see different level of hemorrhages at different ages of hemorrhages, indicative of a non-accidental head injury. So subconjunctival hemorrhage again is the clue here. In a major trauma, subconjunctival hemorrhage, where you can't see the posterior limit, and there is always an ecchymosis or around the eye in both eyes, and is indicative of base of the skull fracture. So it's again a serious problem. Okay, so now we come to another clinical scenario. This is a patient, known patient with ankylosing spondylitis. He presented with rapid onset unilateral pain, reduced vision, severe photophobia, and redness. Again, you can appreciate the redness distribution. He's around the cornea, that is circumcorneal or circumcorneal distribution, or we call it a ciliary flush. It's indicative of acute anterior uveitis. It's very common with ankylosing spondylitis or any other HLA-B27 related spondyloarthropathies. So this patient need intensive steroid. So you need to see the patient very quickly to start the intensive topical steroid, and we needed to see the patient urgently. This is a hyphema, which is a very common complication after the blunt trauma, but it could happen with a penetrating injury and globe rupture as well. So trauma and hyphema is it tells you something. He had a significant injury to the eye. Again, these are a few pictures of penetrating injury. So the people who are working in the A&E, these are, you can see them on the slit lamp. Of course, if the patient is in pain and if the patient is not opening his eye, you can gently open the eye to put some local anesthetic drops to make the eye more comfortable for the patient and examine. In the case of if you suspect a ruptured globe or if there's a penetrating injury, don't try to open the eye forcefully because you can expel all the contents if there's a globe rupture. So you have to be very, very gentle in the case of suspected conjunctivitis, suspected globe injury. There are a few occasions we have to avoid the examination, and we do the examination under anesthesia and do primary repair. There's a serious suspect. Of course, you can organize imaging, CT scan, MRI scan. CT scan is possible in all cases. If you suspect metallic foreign body, you should avoid MRI scan. You should do a CT scan. So in summary, assessing a patient presenting with the ocular complaint to primary care or secondary can be challenging because of the limited facilities you'll have. But systemic approach is needed. If you have the systemic approach, you can narrow down the different cases, and you can identify sight-threatening conditions which need referral to the hospitalized service. And when you're making a referral, you can have a lot of information and adequate information for us to triage appropriately. Because sometimes if you find and if you don't give adequate information, then it's difficult for us to triage appropriately. So I'll give you some clues about when you're dealing with diplopias. So when the patient complains of diplopia or double vision, first you have to establish whether this is binocular diplopia or monocular diplopia. So what is binocular diplopia is if you cover any of the eye, or the right or the left, the diplopia disappears. In monocular diplopia, you have to cover the affected eye. If you cover the right eye and if the patient complains of diplopia, and if you cover the left eye, then the diplopia disappears. That is monocular diplopia. So the binocular diplopia is usually muscle related. Monocular diplopia due to ocular media, either corneal abnormalities or lenticular abnormalities, or sometimes it may be due to the patient's wearing the wrong glasses. So in a binocular diplopia, the patient will complain two distinct images, two separate images, like you're sitting on the car, somebody is driving, he sees two cars side by side or two lanes side by side. So this is the horizontal diplopia that's due to the abducent nerve, 6 nerve pulses. They will see two separate images. So on the other hand, the patient might say, I see two images, but one on top of the other. So, or in a slightly, one image is straight, the other one is on top, but with slant. That is trochlear nerve. So if you remember your ocular anatomy, so we have 6 muscles around the eye, and all 6 muscles are supplied by 3 nerves. One is abducent nerve that supplies the lateral rectus, trochlear nerves that supplies the superior oblique. Rest of the muscles are supplied by the third nerve. The third nerve is the complex nerve, so it has a big nucleus and branches. So the third nerve palsy, very rarely you get the full-blown third nerve palsy. Most of the time you might end up having partial third nerve palsy. So they can cause either vertical or horizontal diplopia. So in a full-blown third nerve palsy, patient will have a complete ptosis. So the patient will not complain of double vision. But if you lift the eyelid, then you will see the eyeball is down and out. So that's the saying. Say if the patient comes with a complete ptosis and you lift the eyelid to see what's happening in the eyeball, you will see the eye is rotated down and out. That is third nerve palsy. And the other condition that can cause either vertical or horizontal diplopia is myasthenia gravis and thyroid eye disease and orbital floor fracture. Of course, orbital floor fracture will have a history of trauma. So some of the diplopias can be variable. So in the thyroid eye disease, the diplopia will worse in the morning and better during the daytime. And in the myasthenia is the other way around, the worse in the evening or when the patient is tired. So these are few clues to identify what you are dealing with and what to do next. So the patient also will have an abnormal head position. So as I said earlier, the trochlear nerve or the fourth nerve supply the superior oblique muscles. If you have a superior oblique palsy or trochlear nerve palsy, patient will have a head tilt to the opposite side. Patient will have a head tilt and chin up. So patient will come to your office like this to avoid the diplopia. He's compensating, he's developing a head compensation for his muscle palsy by turning your head to the opposite direction and tilting the chin up. So when you examine and if you want to demonstrate a diplopia with your finger movement test, patient will not say, you will not be able to demonstrate diplopia. You have to correct the head position to primary position. Turn the head back to the normal position and then now do your ocular motility. You will be able to demonstrate diplopia in the opposite down and out. So in the case of lateral rectus palsy, patient can have a face turn. Patient will come like that to avoid the diplopia. Otherwise, he can't walk. He can't walk with a straight face. So abnormal head position, have a look. When you look at that, then you know we are dealing with the compensated patient, patient with a nerve palsy and head compensation. And if the patient's having ptosis, two possibilities: either it's an oculomotor nerve palsy or myasthenia gravis. If the eyelid retraction is noted, then it's very likely it's probably due to thyroid eye disease. So basic principle is if there's more than one is involved, either lid, pupil, and movement. So the lid is involved, the pupil is involved, the eye movements are involved, or any more than one of that need neurological evaluation and imaging. So in case of the nerve palsy, there will be a ptosis, there will be a pupillary dilatation, and the eye movement will be restricted. Then you have to do imaging to exclude aneurysm, posterior communicating artery aneurysm. So we may have to do a CT angio, MRA to locate the aneurysm. Isolated fourth nerve or sixth nerve, they are often due to microvascular ischemia. Patients often have uncontrolled hypertension or diabetes or multiple medical problems. They tend to resolve on its own. So you don't have to rush and do any neurological investigation for these patients. So it's very important to identify what nerve you're dealing with. Then you can do an appropriate referral and planning the management. That's all I have to say. Am I within the time limit? Oh, sorry, have I?
Thank you, Loganathan, for the very insightful presentation, and it's very, very informative. And we have now have some time for any questions.
Sorry, have I closed this screen or what? What should I do now? Can you still see my screen?
Yeah.
Yes.
Okay.
You can unmute yourself to ask any questions, or you can put it in the chat if you have any.
Right. Can I ask a question, please?
Yeah, go on.
Is subconjunctival hemorrhage in patient who is taking anticoagulants?
Mm-hmm.
Should we do anything for the anticoagulant, like reducing the dose or holding for a few days?
No, you don't have to do anything.
Okay, that's
So tell the
thank you.
patient this is innocent. This is a bleed. That's what I say is bleeding outside the eye, and this will not affect your vision, but it can take 10 days, 2 weeks to resolve. To reassure the patient, I will not adjust the dose. I will not change the medication.
All right, thank you.
I have a question. What is the antibiotic of choice for the preseptal cellulitis? Is it coamoxiclav or?
Yeah, you should give coamoxiclav, and if there's patient allergic to penicillin or cephalosporin, then we give erythromycin.
Okay, thank you.
It's very common with children, so sometimes we get pediatric people to help us. Most of the time, they resolve with the coamoxiclav or erythromycin.
Can we use?
Hello.
And one more question for all the GPs. How many GPs they do fluorescent in your GP surgery?
I don't.
Anyone do it? I don't do that either. Anyone?
It is expensive, so to do in the GP surgery.
Yes, exactly, sir.
I don't think it will be the packet of because it comes as a minims, in boxes of minims. We call them individual vials. So packet of 20 probably comes less than 10 pounds. So you can use for 20 patients.
Unless you do it frequently.
Yeah. I'm not. I don't know. It's very difficult for me to comment.
The GP surgery, we wouldn't do it once in every 3 months or so.
All right. Okay. If that's the case, then it's justifiable not to do. But it will give you a lot of information. Anybody have slit lamp in their practices? Do you all have any slit lamp facilities? Some of the practices do have.
Can we use some hydrocortisone cream for blepharitis?
No. So if you're treating anything to the eyelid, or if there's anything going into the eye, it has to be an ointment. The cream is only for the skin. So if
I mean hydrocortisone eye ointment.
No. So unless you need a lot of supervision, because blepharitis is going to be an ongoing treatment. If you start treating, patient will feel, and you will continue to prescribe. And as you know, the steroid will have a lot of other complications, including this thin skin become very thin, and ulceration. But more importantly, the glaucoma, pressure, all that has to be monitored. If you're putting on a patient for a steroid, be careful. I will not. I don't think anybody does that in practice here.
We have a question in the chat from Sarojini Narendran. How do you treat allergic conjunctivitis related to hay fever in children, which is not responding to cetirizine?
So we usually give if there's too bad. Sometimes we give a short course of steroid, maybe for 6 weeks, 4 weeks, give a short course of steroid, and at the same time we start some allergic treatment. Like we commonly use olopatadine. You heard of that? That's better than sodium chromoglycate or anything else. So try that. That's better. But most of the time you have to give a short course of steroid if this is too bad.
Thank you. Any more questions?
And one more question. You mentioned bacterial conjunctivitis, gonococcal and meningococcal. So what circumstances you get those bacteria?
Actually, gonococcus is a sexually transmitted disease. So, there's a neonatal infection as well when they have a child born to an infected mother. They're usually, sexually transmitted disease. You can start the treatment and you have to refer to the STD clinic for the management. Meningococcal is actually, we don't know, it's very common in the children. So if you identify them, then of course we have to treat very seriously and we have to involve the pediatric team. We can use a topical drop, but patient need a systemic antibiotics for the pediatrics. Can easily go into meningitis.
I don't know whether Deva and Chi, the chat, there is a personal message to you. But there's another question. How long do you give steroid for autoimmune associated conjunctivitis? Do you have to cover with topical antibiotics?
You mean what? Any specific condition is like?
It's coming from Prabhakar. How long do you give steroid for autoimmune associated conjunctivitis?
It's like a bullous keratopathy sort of thing. Pemphigoids is thinking about?
I don't know. Prabhakar can unmute and ask that question.
Oh, hi. Thanks for a good presentation. I couldn't follow the whole thing.
Yeah.
So we have a patient with HLH, and this patient developed conjunctivitis. And
patient, what patient had?
It is lymphohistiocytosis.
Okay.
So this patient has developed conjunctivitis, and the ophthalmologist started on steroids and topical antibiotics. And he didn't mention how long to continue for. I stopped it after a week. Is that okay?
I really don't know the answer. You have to have a specific. So any autoimmune system. So basically, you can start some local treatment, but these are immunological disease. So you have to suppress the immunity systemically. So some form of systemic steroid or other medication to modulate the immunity. Topical steroids sometimes can give a quick symptomatic relief, but once the systemic treatment is started, usually you can tail off.
Yeah. He received systemic treatment, so that is stop. I mean, he got anakinra and he's on prednisolone now. And on top of that, the ophthalmologist prescribed this. So the disease is suppressed and he's better. So I just want to know whether I could. I just on the topic today. I want to know whether it is okay or not. Otherwise, I laugh.
Yeah. Because if I think if it is already on systemic steroid, maybe justify to use topical steroid time to time if there's a flare up. But I won't use it for a long time. So if you use it for a week or maybe 2 weeks to suppress the inflammation, because chronic use of steroid is not good, in any form of steroid. So unless it's monitored carefully. So I really don't know the answer. These are complex cases, need to be.
Okay. No worries. Thank you. Thanks, Loga.
We give a few more minutes for any final questions.
There is no more questions. I think that we can wrap it up.
Okay.
There's a certificate available. Please download on the chat box.
Okay, for me, yeah?
For everyone.
For everyone.
Oh, okay. All right. Okay.
Attendance certificates.
All right. Okay.
So thank you once again for everyone for attending, and our special thanks goes to Loganathan for sharing the expertise with us.
Pleasure.
This brings us to the end of this webinar, and we will meet you again with another interesting topic in near future. Thank you.
Thank you for giving me the opportunity to interact with you. Thank you.
Okay, there one question. You know me. I came to your house, I think, 35 years ago. No, 30 years.
If I see your face, I will remember. Can you come on the
Logan, how old are you now?
I'm nation friend, nation batchmate.
Oh, my brothers. Okay.
Yeah.
If I see your face, I will remember you. Can you come on this camera?
My video is there. Yeah, that's right. Yeah.
Yogan, I am other Loganathan. I am the eldest.
Oh,
Loganathan.
yeah.
Oh,
eldest
yeah.
I know you. Brother
My
Yogan,
Anna,
yeah.
yes. Anna is the other side.
We studied in the same place, but my younger brother studied in Colombo.
நான் உங்களோட வீட்டை ரொம்ப தரம் வந்திருக்கிறேன்,
I know.
சாப்பிட்டு இருக்கிறேன், டீ குடிச்சிருக்கிறேன். உங்களோட அப்பாவோட நீங்கள் இல்லாத சேட் பண்ணிருக்கிறேன்.
Okay. That's a nice memory. Thank you very much.
Loganathan, so if you can unshare பண்ணீங்கன்னா, then you can see the others up here.
Okay, stop sharing. Sorry.
Stop sharing. Yeah.
Okay.
So now you can see.
Now I'm 57 years old now.
So I can't see your face.
Here.
Okay.
Can you see?
Oh, right. Okay.
Hi, Dr. Logan.
Hello.
Dr. Loganathan is from Seychelles. Dr. Vivek.
Okay.
Dr. Vivekanandan.
All right. Okay.
I think he's the one put a private message, but I didn't want to read it. You can read.
Sure. Just is it you, the same Loganathan I am referring?
Yeah.
Yes.
Ramaniakas.
I think there are three.
Lovely.
Okay.
Three.
How is Mitilaka?
Mitilaka is fine, Appan.
Good.
Yes, you want to have a word with her?
Oh, my regards. Oh, yeah. Why not? Is it allowed this?
This is out of our setting.
Okay.
Yeah, it's 1:14. I am in India now. Your friends? No, I was in UK for a while.
Right.
Yeah. He's sleeping 1:30. Just
all right.
Just I think online.
Hello. I can't see the photos, all the photos. I don't know what am I doing wrong.
No. I think it's okay. I can see you.
I can't see.
Hello, do you know me?
Yeah.
Ramanina Tambiya?
Oh, Mama, Ramanina Tambiya.
Okay, எனக்கு மூத்தண்ணாவை தெரியும், உங்களை தெரியல.
Right. Okay.
எப்படி இருக்கீங்க? Where are you now?
I'm in UK. I'm fine, very good, doing well. Anna Nikrar actually on the.
Anna I know very well. He's a member of COS 90.
I don't know that part. I know.
Okay, then.
Thank you
Nice
very
to
much.
talk
Thank
to
you.
you.
Nice to talk to you. Nice to talk to you, Rebecca. Thank you very much. Thank you. Oh, it's a nice catch up.
Okay, pa.
Thank you
So
very
I'm
much.
living in Cyprus now.
All right. Okay.
What a friend I was there a couple of months ago.
Okay.
Now only then I will arrange Chandichanan.
Right. Okay.
At a Ashok arrange Chandichanan. I had a neurological problem.
All right. Okay.
Yeah, they knew. What a friend Chulwer.
Okay. Okay.
Okay.
Okay.
She is in touch with other sister.
Pleasure.
Adigadi Kadepa.
Yeah. Okay. Nice.
Okay, da.
Thank
Nice
you.
to talk to you.
Thank
you
you.
for
Thank you.
listening.
Thank you. Thank you.
Thank you for Dr. Kodas and eye surgeon conducted a revision after many years.
Okay. Okay.
Yeah, that's great. Convey my regards.
Riaz, thank you very much. Pleasure talking to you. Pleasure talking to you. Yeah.
Okay.
Thank you.
Okay. Bye.
Okay.
Yeah.
That's a nice catch up. Thank you.
Oh,
We'll wind up.
okay.
Bye.
Okay. Thank you. Thank you, Deva. Okay.
Thank you.
Can I
Thank you
close?
very much.
Thank you. I close this.
Thank you very much, Nishan. Yeah.